Dear friends, it's really a great pleasure and honor indeed for me to be here this morning and to interact with a very eminent cardiologist from Mumbai, Dr. D.B. Pahlajani. Dr. D.B. Pahlajani does not need any introduction to the audience of India as well as the world. He is the past president of CSI and a very eminent cardiologist of Mumbai, known worldwide. Dr. Pahlajani, welcome to the studio. And especially we are going to have a good discussion today on a very important subject. We talk of primordial prevention for the heart diseases, we talk secondary prevention, we talk of tertiary prevention, and we also talk of primordial prevention these days. My focus of interaction with you is only on ST elevation MI. We are talking of tertiary prevention, what we should do, what we should not do. We know in India, there is so much of crowd on the roads, so much of rush traffic on the roads. We find there is a lot of time delay, and we all know that it is a time which is a muscle. If there is a time delay, we cannot salvage the jeopardized heart which is under stress because of low circulation, which is 100% blocked, and by the time they reach to the hospital, the heart muscle is already damaged. Now there are two kinds of setups in India. There are some where there is a PCI capable, there are percutaneous intervention, they can straight away patient can go for intervention, that's an ideal, there is no doubt about it. But the question is, 95% of our patients don't reach in time. When we say time, they should reach within 2 hours if we really want to have a benefit of PCI. So we like to ask you a question, if the PCI capable center is at a longer distance and a patient had a heart attack which is confirmed, diagnosed at the site of issue, problem which had happened there, either in the office or home or anywhere in the working place, and if he has to go to a nearby center which is non-PCI capable, what are your recommendations? What is your message that how they can be managed meticulously at that point of time and subsequently? Dr. Pahlajani sir.
First of all, Chopraji, thank you very much for giving a very sort of a kind introduction, and I'm really indebted to the conference that you're holding and having invited me to address your audience here. It's a very important topic, to be precise. If you see that in this country there are about 3.5 to 4 million individuals who develop ST elevation myocardial infarction, and as it may, the mortality of this kind of an infarction outside the hospital is close to 15 to 20%. So until unless they receive an appropriate treatment on time, the mortality is going to be very high. It's not only the mortality, it's also the morbidity. These patients will have a very bad ventricle, so they will have left ventricular failure, cardiogenic shock, arrhythmias, and their long life, even if they pull through this kind of an episode, is going to be very sort of a cripple. So therefore we'll try to save them and save the muscle. I think these are the two most important issues. Now you pointed out very rightly, leave aside in the outside areas of the metropolis. Even the metropolis itself, you see the city of Mumbai, Delhi, Calcutta, you see the streets are choked up with the number of cars. You can't, there are no dedicated lanes for the emergency services like ambulances, police vans, or the fire brigade. Even fire brigade gets stuck up. So how do you manage them? So I think there is a solution available, and that solution is not just sort of out of the air, but it is based on the solid evidence-based medicine, on the strength of several trials which have been done. Now, some of these trials are what is called as a fast AMI trial, which sort of is very oft-quoted, in which they have found that suppose you find a patient who has got a heart attack or ST elevation myocardial infarction, goes to a community hospital. Community hospital means peripheral hospital. These are not PCI capable centers. Now the transfer time may be 2 hours, 3 hours for him to reach the hospital. the hospital itself may take some time to take him to the lab to do a primary angioplasty, because we know that primary angioplasty means door to balloon time of less than 90 minutes, which may not be possible. So what they found, that if you give a thrombolytic or a fibrinolytic treatment at the community center, then what is called as a systematic PCR, not even deferred. So if it is done 2 hours after the administration of the thrombolytic treatment and done within the first 12 to 24 hours, maximum 24 hours, they are taken to the cath lab, you do an angioplasty, what is called as the pharmaco-invasive therapy. On one side you are given a pharmacological treatment, on the other side you are done an invasive treatment. So you do a pharmaco-invasive treatment. They have found that the mortality, the benefit of this kind of an approach is as good as that of a primary PCR. I think for a country like ours, perhaps this model may be comparable to the primary PCR. Of course, primary PCR still remains the gold standard. Suppose somebody who stays within few 100 yards of the hospital, PCR capable hospital, he can be transported there. That's a different thing. But what issue that you have raised, it's a very important issue. It's a realistic issue in our country.
I think Dr. Pahlajani has given a very clear-cut message. That anybody getting an ST elevation MI or a heart attack or a major heart attack and is not in the vicinity of the hospital where PCI is possible, the message is very clear. All these patients should be given a clot buster or should be given a thrombolytic therapy in the form of tenecteplase or alteplase or many drugs available as third generation thrombolytic agent. And after thrombolytic agent, he was very specific. He mentioned within 3 hours to 24 hours, he has to go for angiography, then he should go for PCI. He used a very good word, what we call as systematic PCI. He also used the word selective PCI. I think we have to understand every patient, if we give a clot buster, clot may dissolve to some extent, at least we save the damage to the heart which is already in risk. And once that is taken care of, patient can be transferred to another center within 3 hours to 24 hours. If we subject him for PCI, we can give him a good life. He used a very categorically, that we don't reduce the mortality, but we also reduce the morbidity. And that's what he says is feasible and practical. Dr. Pahlajani, it's very important. In India, the awareness, the education skill is very poor as compared to the Western world or European world. Do you think, is there any need of a smart heart app where a common man can be educated on the symptoms of heart attack and he doesn't waste time eating some local things like ajwain they take, or they take some salt at home or a home remedy, or they call a chemist shop and take a pill, discuss with the chemist, or they talk to a general practitioner? I think this is just a waste of time. They should straight away talk to the hospital doctor for such a thing only once they know that it's a heart attack. So what do you think if we have an app like a Heart Smart app in India, in every possible state of India or the city of India or a village of India, and that app should be both in English and Hindi or multiple languages, and we talk of component A as symptoms of heart attack and its feasibility.
I think it will definitely help him. Dr. Chopra, I feel that tackling ST elevation myocardial infarction is a program. It is not individual's job. It is not your job, my job as an individual. It's all right for the patient to interact with me. But if you want to save lives, in number of, say, hundreds of thousands of lives, it's a program. In the program, I think everybody has to participate, like government, the local civic bodies, the lay public, the social organizations, the hospitals, the doctors. All of them have to participate to say, okay, here is a situation which is crippling the nation. There are, as I said, 3.5 to 4 million patients getting heart attacks every year. In Mumbai itself, I have got the data. last year 30,000 individuals out of 90,000 died of heart attacks. These are the Bombay Municipal Corporation's data. Now, if so many people are dying, we have to save them. It has to be saved only by a program. Now, the app can be a part of this program. It can be initiated by either the academic bodies, or it can be initiated by the government or the local social agencies. So I think app is a very, very smart idea. It can be on a smartphone, that okay, a point 1, 2, 3, 4, when somebody gets chest pain, I think what you should do next.
I think it's a very brilliant exposition. Dr. Pahlajani is very vivid in his statement. And the statement is, there is a tremendous need of a smart heart app, which must have a first component, how to recognize the symptoms of heart attack, and then how to attack heart attack. How to attack heart attack should also be a second component of it. And this is possible that once we diagnose it, he was very specific. It is not an individual responsibility. It is the integrated system. We create an app, and there should be integration in a manner that everybody is aware, and we create a system so that component 2, a mobile section should be there of emergency hospitals, maybe community based or PCI capable based, city wise or state wise, so that we press the component. If I am close to India Gate in Delhi, I know which is the hospital nearby, and straight away I press that button and the ambulance reaches in 5 minutes. And the clot buster can be given only after doing an ECG. ECG can go by telemedicine to the nearest doctor, who can pass on the instructions either through the WhatsApp, that here is an ST elevation MI, and the paramedical staff which is there under the supervision of a cardiologist can give a clot buster right there, by which we can abort MI, or we can make a larger heart attack to a smaller heart attack, or a transmural to a subendocardial, or we can prevent the extension of a heart attack, or prevent the complications of a heart attack. I think that's the only way. This is easily practicable and working in United States.
Actually, you pointed out a very important thing. I think, as a matter of fact, looking at today's time, what is available, as a matter of fact, there's no need even for an elaborate telemedicine center. Just a simple WhatsApp. What you pointed out, WhatsApp. Many times my residents from, say, emergency medical services, they say, sir, patient is admitted with chest pain. I'm sending the ECG to you on WhatsApp. While sitting at my home, I find something little abnormal. I say, okay, send the blood reports for the enzymes like troponins or CPKMB. I say, now you repeat the ECG. So while sitting at home, I don't have to even have an elaborate telemedicine. So I think the patients can take use of the smartphone and send on the WhatsApp, send to the doctor, and then center will decide whether the patient needs to come to the center.
So I think here is Dr. Pahlajani, who is a smart cardiologist, who believes in a smartphone and who believes in a smart heart app. And he says telemedicine is not required. Why should you go for a costly stuff? He says just app is enough. App gives the same information. Sitting at home, sitting at center, sitting anywhere in the world, you can get the information, a display of the EKG, you can get the report of tropi, you can even see which patient is given what, and you can give a clot buster under supervision and then shift the patient to PCI. I think that is the only practical thing. You'll be very happy, Dr. Pahlajani, that we have taken the initiative in CSI, and the first smart app will be launched in cardiac prevent. This is just a beginning. This is at a national level we are doing it, and I'm sure every city, every center of CSI will take the responsibility. Your point is very well taken, sir. You mentioned it is not the domain of only one association or organization. It can be Rotary, it can be local welfare society, it can be non-NGOs, it can be government organization. Everybody has to be involved. If we all are involved, then we can save the heart. That awareness has to be there. Right. So I think you'll be very happy to know, sir, this is for your information, that we have started Save a Heart mission. Yeah. I say our focus has been of WHO. I had been seeing they're talking of primordial prevention, primary prevention, secondary prevention, but nobody talks of STEMI care. The time has come, we have to change our perception and change our paradigm shift, to how we can salvage the heart attack patient, because they are very important people. They are very important to community, important to nation, important to their family in 40s or 30s, and they pass away and we are helpless. 50% of patients they die at home, sir. 20% on the way. It's only 30% we save. So I think with your wisdom, the way you expressed that we don't want to go for telemedicine, just an app is enough, and that is going to help us a lot. I'll ask one thing more, sir. What are your recommendations as a past president of CSI to enhance the awareness besides an app? Either we create an awareness through their website and have a link with various organizations so that there is an awareness campaign, or we use IT-enabled hoardings all over India, so that aim is only IT, sir, or we go in a digital way. Here we are in the digital health. People are talking of digital health, so we go to a school, we go to a college, we go to organizations, we go to public sector undertaking, and we go all over the world. What's your word of wisdom on this?
My word of wisdom is only one: spread the net.
Excellent.
Spread the net. It could be, as you said, Rotary organizations. I think Rotary organizations time and again should be sent some sort of a handouts so that they distribute amongst their own members. Because ultimately, as you know, Rotary, Lions Club, they are spread all over the country. So I think if we send out the messages, as a matter of fact, to save the cost, I think you are tech savvy. I'm also. So, to sort of put it on the hard copies may cost a lot of money, but at least it can go on the net, sent to the president and the secretary of every organization that please read it, a very short message, please read it to your members, maybe just like a prayer, read it to your members every month in their meeting, okay, and stress upon them that if they encounter any chest pain, which is for the first time in their life and is in the center of the chest, please do not ignore it.
I think it's a very important message given by Dr. Pahlajani as a past president of CSI, and I am the national president of CSI. I am going to implement everything the way Dr. Pahlajani mentioned. He said a time has come, we have to enhance or extend the potential of a network. It is the network which can save the myocardium or the heart attack. And we have to go to every nook and corner so that people should have an awareness about the heart attack. Just by bringing drug or just by bringing a cath lab, even a mobile cath lab will not be able to help if there is no awareness. So awareness is the first goal. How to tackle subsequently, I think a very nice idea given by Dr. Pahlajani, that app is the answer so that they understand, and then we have to provide the mobile services. We have to have a network with emergency services. So everybody should have an education and knowledge, and then come the PCI. We are not ignoring PCI, there is no doubt, and Dr. Pahlajani was very meticulous. The gold standard is PCI, but the limitations are there. So we have to see that in those limitations, what we should do, and our goal is only one, that we should save the heart which is under risk. We are very grateful to you, sir, for your words, and I'm sure we are going to implement it in a very subtle way. We already approached the Prime Minister of India to launch this app in the Cardiac Prevent in Delhi, and we are creating a huge network, but just a beginning service starting from there. And we are also having a Save a Heart mission in the form of a mobile van, which may also be launched by the Prime Minister, and you will be there as a past president of CSI, as a father figure, and your coming and your blessings will be of a tremendous application, and it will help us how to treat an ST Vaishnavi in a center where PCI is not possible, and how a patient can be given the maximum benefit despite not having a PCI capable center, but can be sent to PCI capable center after the primary treatment is given by clot dissolving drug, or by aspirin, or by statins, or by clopidogrel, and then subsequently managed so well so that the damage is minimized and the morbidity and mortality can be improved. Let's give a big hand to Dr. Pahlajani for his words of wisdom.